Many of you either know someone with cancer, have had cancer yourselves, have gone through the process, or may be about to go through this journey. So wherever you are, please feel free to ask questions wherever you're coming from. My name's Phillip Beron. I'm one of the radiation oncologists at UCLA. For those that don't know, cancer patients will often be treated with three types of oncologists: a surgical oncologist who may do surgery, a medical oncologist who will do chemotherapy and maybe some other kind of medications, and then a radiation oncologist who uses X-rays to not take pictures but to destroy cancer cells, and that's what we do. So that's what this talk is going to be about. I've been asked to talk about some more current radiation techniques for lymphomas, both the non-Hodgkins lymphomas and the Hodgkin's lymphomas. We can talk about that and what those differences are a little bit. But before I start, I noticed some of the other talks against the wall, and I thought they were very interesting. So I grabbed some of those. There's the prostate cancer physician panel that 5 people have signed up for. And then the 2 that I thought were most interesting, which was the mud walking, which I have no idea what that is, which another 4 people have signed up for. And then my personal favorite, which was entitled, "Stop Holding the Door Open with Your Butt," which has 25 people signed up for it. I don't know what it is, but apparently it's very popular. There are two radiation centers at UCLA currently. One in the Westwood campus, which is where I am, and that's where I'm chief of the lymphoma service, and I'm also chief of the breast service in Westwood. And then there's our Santa Monica, a smaller department that also has radiation as well. Well, for those that don't know, this is the kind of outline we're going to talk a little bit about today. We're going to talk a little bit about Hodgkin's versus non-Hodgkin's. What are the differences? When do we use radiation? What are some of the techniques of radiation? What kinds of machines do we have available? We have a new patient video that I think might be interesting for you. And then I wanted to talk a little bit about technology, because my field is so technology driven that what we do, technology really matters and can make a big difference. So in terms of the non-Hodgkin's lymphomas, there's 2 types of lymphomas in general: Hodgkin's and non-Hodgkin's. Perhaps you know somebody or have had that yourself. Hodgkin's is the one that gets the most attention because it was named after a gentleman named Thomas Hopkins back way when, where he discovered this particular type of lymphoma. And the Hodgkin's and non-Hodgkin's lymphoma are have a long history in radiation therapy because they're very sensitive to the treatment. So we can destroy lymphomas much easier than we can some other kinds of cancers like prostate cancer, breast cancer, and lung cancer. So lymphomas most of the time are more curable, and they can be cured a little bit more easily than some of the other cancers can. They're common cancers, the 7th most common cancer in the United States. They're, like most cancers, a cancer of age, and they seem to be increasing. I'll see if I can do this right. They have had a doubling of their incidence in the last 20 or 30 years, especially from 1970 to 1990. And a lot of that may be explained because we were getting better at our tools. Our imaging and our diagnostic tools were improving at that time as well. And so we got better at diagnosing things. There's also an increase in Hodgkin's and non-Hodgkin's because the population's getting older. And then in the 80s, HIV reared its ugly head, and that also led to some people getting Hodgkin's and non-Hodgkin's lymphoma. And then we're a little bit more in tune with some of the environmental exposures. So what are those kinds of exposures that could lead to lymphomas down the road? Well, we know there's an increase in farmers, people that work in the dry cleaner business, butchers, printers, woodworkers. So certain occupations may give you a slightly increased risk of lymphoma, as well as some pesticides and hair solvents and asbestos and things that you generally don't want to be around. But unfortunately, some people are. And there's also increases in lymphoma in people who've been around the radiation industry or atomic reactors, or have just gotten radiation therapy or chemotherapy. Somehow the radiation and chemotherapy alters the DNA a little bit and leads to an increased risk. The problem with speaking about lymphomas is it's much harder to do than talking about prostate cancer or talking about breast cancer, because those everybody knows. You have breast cancer, it's in the breast, they're relatively the same. The lymphomas are all completely different. That's a different lymphoma than that, than that, than that, than that, and they all have their own personalities. And so this is the list. I'm not going to bore you enough to read that, but these are all different kinds of lymphomas. And so when we say somebody has lymphoma, the broad category is non-Hodgkins and Hodgkins, but within non-Hodgkins, there's like 40 different kinds of lymphomas. And so that's what makes it a little bit more difficult to get up here and talk about lymphomas, because no two lymphomas are the same. Everybody will have a different experience. And all of these lymphomas, to further complicate things, can happen anywhere. So you could have a lymphoma here, or the same lymphoma here, or the same lymphoma here, and the treatments are kind of different. And so that's why it makes it a little bit more challenging. I saw a hand go up over here.
What is the common characteristic that makes it a lymphoma?
What it looks like under the microscope.
Okay.
Lymphomas generally are tumors that start in the lymph nodes, right? And we have lymph nodes that go from the bottom of our skull through our neck, into our underarm, into our center of our chest, into our abdomen, into our groins, into our pelvis. The spleen is a big, huge lymph node, basically, yes, and that can be involved as well. So lymphomas are generally seen in the areas that have lymph nodes, typically. There is a category of lymphomas called extranodal, which actually start in areas outside of the lymph nodes. We'll talk about that just a little bit. But generally, they're starting in the lymph nodes, and that can be in the middle of the chest, that can be in the neck, that can be in the groin, that can be in the abdomen. There's no rules. And that's, again, why it's a little bit more challenging, right? Because when we say breast cancer, we're kind of sure we know where that tumor is starting and what the treatments are going to be. But lymphomas, as you'll see when we talk about some of the radiation techniques, are all over the place. Here's a very common type of lymphoma. We call this a slightly more aggressive kind. It's a common called diffuse large B-cell lymphoma. And it looks like this under the microscope with this sort of diffuse growth pattern. It's very common. It represents about 1/3 of all lymphomas. And here's a very different kind of lymphoma. This is a very more non-aggressive. We call this an indolent lymphoma. This is a follicular lymphoma. It's the second most common type of lymphoma. And those two treatments are radically different. For the diffuse large cell, there's certain kinds of chemotherapy and then radiation, and we treat them in a very serious way. These, it can range anywhere from observation to some mild chemotherapy to maybe just radiation in certain cases, and so the treatments are very, very different, but yet we call them both lymphomas. Now you're starting to get a sense of all the disparities within this lymphoma category. This is that extranodal kind of lymphoma that I was talking about, where usually lymphomas start in the neck. In these cases, they can start in the eye. You can have a lymphoma of the breast, the stomach, the thyroid, and the skin. These are all areas that don't have lymph nodes, basically, and so we call them extranodal. They're not starting in the lymph node. And that's a separate category of lymphomas that are very, very common. Here's the kind of testing somebody might go through when they're told they have a lymphoma. This is what we call the workup. You're going to have a physical examination, some blood studies, maybe all of these blood studies. You're probably going to have a bone marrow biopsy or a bone marrow aspirate, which is usually done in the hip. And then we're going to have these kinds of imaging studies, chest x-rays, CAT scans, maybe a PET scan. So there's quite a bit of workup, both from the blood work and the imaging that goes into lymphoma workup. This is an example of a PET scan. And a PET scan is where we take a combination, it's called a PET CT, where we take a CT, which are the pictures you see, and we marry that to a scan that looks at radioactive glucose, because tumors like sugar. They like to eat sugar. And so when you put a little radiation in the sugar and inject it into somebody, it lights up. And so this is the tumor. This is the pre-treatment, and this is the post-treatment. And so this is the tumor right here in the chest and in the underarm area. This is the heart, and the heart likes glucose too, so you can see the heart has a little bit of glucose in it. All the rest of this is pretty normal except for this spot, but this is the main area here. And then after treatment, you can see that all of that area that had previously lit up is no longer lighting up, and so that lymphoma is now dead in this area. That's how we might use imaging, not just to diagnose a lymphoma, but then also track its progress, track its destruction before and after treatment. So again, before, lighting up, after, no more lighting up. That's a very powerful tool, and these are really only recently done in the last 10 years. This is not something that was available certainly when I was in med school or residency.
What's that one that's really lit up?
This one here?
Yeah.
That's the heart. So that's normal. The heart is always going to light up. So is the brain up in here.
Yeah,
It always lights up.
It's lit up a lot more than in the other one, though.
Yeah, that's normal though. The heart beats at different phases and it uses glucose differently, so that's
okay.
completely normal. It's also normal here. This is the bladder. That's also completely normal. Yeah.
Thank you.
This is the abnormal spot right in here. And then every time somebody is diagnosed with really any kind of cancer, not just lymphoma, they go through the staging process. And lymphomas are staged as stage 1, 2, 3, and 4. And it's a matter of really where it is. The staging system is 30, 40 years old now. It's not sort of kept up with some of the current technology. And so basically, it's just telling you you have one site of disease or two sites of disease on one side of the diaphragm. The diaphragm is what helps us breathe. And stage 3 means that it's on both sides of the diaphragm. So it's a pretty rudimentary staging system that has served us well, but is in the process of being updated. These are some much older techniques that we don't really do anymore, where we would treat the whole abdomen with radiation. This whole area over here would get varying degrees of radiation. This is a very old picture of a radiation technique called the moving strip, where we would treat this strip, then this strip, then this strip, then this strip. We don't do this anymore. This is from the 70s and 80s. These are kidney blocks. These little round circles are, or were, our best attempt at blocking the kidneys back then from the radiation. You'll see the difference to the current techniques. I think it'll be quite evident. I just wanted to show you some historic techniques. This is a more modern kind of picture where somebody has undergone CAT scan, MRI, and PET scan imaging, and we have gone in and now we have more certainty where all of your normal structures are. So here's the liver, here's the kidney, here's the kidney. These are the bladder and prostate areas and the lymph node areas and the pelvis. And so now, through computer contouring, we're able to draw things in and have basically sub-millimeter accuracy. So we're able to take our imaging, our PET scan in this case. You can now you're all experts. Now you know that what was bright before, these bright areas, not good. That's where the tumor is in this case. It's a lymphoma in the chest, here, sitting here, and up in here. Here's the lymphoma here to look at it in a different way, these little areas over here. And then you can see that after therapy, we're able to track this with the PET scan. Those areas are now no longer lighting up. And that patient, we would say, you could say they were in remission, they no longer have active disease. There's different ways to term that. This is a more now fancy technique where when we use x-rays, let's say that the purple area is now lymphoma, And these areas in the speckled colors are lung, and this area in red is the heart. Part of our job as radiation oncologists is to not only give as much radiation to the tumor, that's good, but also to give as least amount of radiation to the normal structures. So we're always fighting this balance of giving enough treatment to the tumor to destroy it, but not giving too much to the heart and lungs and spinal cord and other normal structures so we don't hurt the patient any more than is absolutely necessary. And so there are lots of new techniques, all of which we have in Westwood and Santa Monica. This is an example of something called deep inspiration breath hold, or DIBH, where we only treat, the machine only turns on when the patient is holding their breath. Holding their breath gives us great advantages in that it moves the heart down, and it can move the heart completely out of the field. We also use it quite a bit in breast cancer. In women that have left-sided breast cancer, the heart is much closer to the left side. And so the heart dose for breast cancer patients can be very high, and with deep inspiration breath hold, we can reduce the dose to the heart 75% sometimes. So that's quite a bit that wasn't available before. This is another kind of technique called IMRT, or intensity modulated radiation therapy. This is a fancy technique that also was not available when I was in training in the 90s. This is where we're able to tell the computer, please, Mr. Computer, we want to give this much to the target or tumor area. We want to give this much to the other areas, and we want to limit the lungs. And so what you're looking at here is a CAT scan. The black areas here are the lungs. This area is the heart, and this is the diaphragm. And the area in red is the tumor, and we're trying to get as much dose to the tumor while sparing the lungs and heart again. And so everything within this area is being treated. Let's say this yellow line, that's probably the line that shows up the best. That's all receiving dose. So you can see there's some lung that's receiving dose, and we're trying to spare all this other stuff that's very close by. We're talking sometimes millimeters, centimeters in proximity to the tumor, and so we're always fighting this balance and this war about keeping the lung. We have certain constraints that we're trying to keep the lung dose to, and it's a battle, and we have a team of people, not just the doctors. This field of radiation oncology is very different than most fields. We have a team of medical physicists and dosimetrists, and so every plan, all of these plans are originated with the doctor, and then the team of medical physicists and dosimetrists will do maybe 3 or 4 different plans, because there's different ways to do these plans, and come up with the best plan for the patient, and then we'll study those plans and decide which plan is best for the patient, and then which machine is best for the patient, and how much dose is going to the lung, and how much dose is going to the heart, and what is best for the patient in that particular instant. And every patient is completely different, so there's not a cookie cutter that would fit any one patient. This again is another way of looking at these lymphomas. Again, this shows you how many lymphomas there are. And there are some that are much more common than others. I've circled some of those. You might have heard of something called a MALT lymphoma, or a B-cell lymphoma, or a T-cell lymphoma, or a follicular lymphoma. Each of the lymphomas can be looked at under the microscope, and although these look very similar to us, to a pathologist, these are very different. This is a very indolent or non-aggressive lymphoma, and this is a very aggressive lymphoma, and it has to do with the pathologic characteristics. Also, something I think that's very handy for people when they're deciding on treatments and trying to understand what their doctors are recommending are something called the NCCN guidelines. The NCCN guidelines stand for the National Comprehensive Cancer Network. This is an organization that puts the best minds together for each cancer site. So there is a booklet that they put out, and they update every single year. You can go to their website. It's free. You just need to sign up, but it's completely free. There's a physician section. There's a patient section. And they put together these, and this happens to be the physician section, so it's a little bit more complicated, but assuming you have this follicular lymphoma and this is your stage, these are your treatment options, and then here's the sort of pathway of what should or could or might happen to you as you're going through these treatments, and these are the options of treatments. Here, there's an option for radiation or immunotherapy with radiation or observation. This is that non-aggressive indolent type of lymphoma known as a follicular lymphoma. This can be a very confusing type of lymphoma because the options range from radiation to chemotherapy, immunotherapy, to doing both, to then doing nothing. You can see how confusing that might be for a patient. But the NCCN guidelines will help explain why that is. And if you look under here for this particular lymphoma, the real recommendation for a stage 1 follicular lymphoma is probably radiation therapy here. And there's a little note that I've circled here that says observation may be appropriate in circumstances where the toxicity of radiation may outweigh the benefit. And so they leave a little basket of consideration for people who might not be good candidates for radiation. And so these are very helpful. They come in different kinds of flow sheets, none that are this complicated for the patients. And here is the kind of radiation and how it's evolved over the years. This particular person has a lymphoma. This is the pelvis area now. Here's the hip bones, hip bone, spine. And in the 80s, 90s, and early 2000s, if a person had lymphoma here on these dots, this was the radiation field that we used, this yellow. We treated something called involved field radiation. That was what people got from New York to Stanford and everywhere in between. We still do some of that for certain types of lymphomas, but generally now we're treating this blue area, or even smaller in some cases. We've got our targeting down now, and we've got our imaging down now, and our diagnostic capabilities down now, where we can generally treat a much, much smaller area and get the same results as treating this through different combinations of chemotherapy and radiation and the way things are put together. It's been a great breakthrough to be able to shrink the fields down and give less side effects to the patient, because the one thing we know about X-ray treatment or radiation is you can only have side effects where the beam is pointed. And maybe this is probably the most important thing I can say today. The only area that's getting radiation is, in this particular case, in the yellow. And so the only area that can have side effects is right here. You can't have side effects here. You really can't have side effects anywhere else. And I say this because I have so many people that are being treated for, I don't know, breast cancer or prostate cancer, and they come in and say, wow, doc, ever since you started that breast treatment, I've had this weird headache, or I've had, my knee hurts. And it's absolutely impossible that it was from the radiation. But as human beings, we relate everything to time and space. And so if you get a pain and I happen to give you a treatment 2 days before, you'll sort of relate it to the treatment that you got, even though it had nothing to do with it. It would be like saying you had a surgery on your breast and 2 days later you got a knee pain. It's impossible as well.
What about urinary incontinence and prostate radiation?
Well, that's because the radiation is going to the bladder area at that point, and so completely due to the radiation can be. That's right. But that's, again, it's all about real estate, real estate, real estate, location, location, location. We're treating the bladder, prostate area, you can have urinary issues. We're treating the breast area, you can have breast issues. We're treating your tongue, you would have tongue issues. But you can't have tongue issues if I'm treating your prostate. That would be impossible.
Salivary gland issues?
If we're treating your prostate, no.
Tongue.
Yeah, of course. Anything that's in the area can be affected, but it has to be in the area. That's the whole point. So these are, there's a group of people, the International Lymphoma Radiation Oncology Group. Oops. the ILROG, and a group of people that consistently, year after year, are finessing the recommendations and the treatment techniques. I've put together a couple of examples of cases and how we treated them that I thought might be interesting. The first is a 48-year-old male who presents with disease in his underarm. He came out of the shower one day, he felt something, and they did a biopsy, and lo and behold, it was a diffuse large B-cell lymphoma, and if you recall, that's one of the slightly more aggressive lymphomas. He underwent a PET scan and that workup that I talked to you about, and the treatment plan for this gentleman was something called R-CHOP, which is chemotherapy, and then involved site radiation to the area. And so his treatment, before he was treated, his scans looked like this. This is his disease right here. And these can be kind of scary looking, right? That's a non-trivial matter if it's growing in your underarm. And that's what's growing in his underarm. Now you can see the rest of his body's actually pretty good. This is what it looks like on a PET scan. It lights up very clearly. And so we are very good now at targeting these kinds of areas. And after radiation and chemo, after chemo, it goes down to about that big. The chemo is able to shrink it to about that big, and then the radiation will be given to this area. You can see we're carving out this area. Here's his lung. We're giving this precise treatment to his underarm area, the lymph node areas, and the PET scan then becomes negative at that
Depending
point.
upon stage, is it one size fits all?
I'm not sure what that means exactly.
Okay. If it's the same stage, and the patient is an offensive 300-pound tackle in the NFL that weighs 300 pounds, does he get the same amount of lines of radiation?
Oh, I see what you're saying.
Same size,
Um,
same type, same stage? As a
The best way I can answer that is this. If we decide to give him the same dose as we gave somebody else, so it's not a one-size-fits-all. There are different doses that we select based on their PET scan. Not everybody has perfect PET scans after chemo. There are different doses that we use for different PET scan responses. But let's say we wanted to give U3000 and U3000 and then a NFL linebacker who weighs 400 pounds, 3000. You would all get 3000, but it would all be done very differently, and that's where the medical physics team comes in. They have to calculate the body circumference and the weight and how much tissue the beam has to travel to get to that 3000. And so skinny people have different treatments than heavier people, but the dose is the same. It just gets there differently because of the physics involved.
I think up until several years ago, that was not the case.
That's been the case for a long, long time. So yeah. This is just a different way of looking at here's his head here, here's his jaw, and then here's his underarm. His arm's in the air, pointing up like this. And so this is where the radiation is going in this particular gentleman. Here's where his PET scan was positive in red. This is a very different kind of case. Now, this is a 63-year-old woman who felt something in her right groin. She felt a little bump, and lo and behold, she had a little bit of a bump right there. And this was what we call a follicular lymphoma, which is one of those indolent lymphomas, not super, super aggressive. And this one could be treated with no chemotherapy and just radiation therapy to the groin. And so she would get a treatment that looked something like this. It would treat a very small part of her. Her side effects would be very, very minimal because we're really not treating any organs. There's no bladder in the area, no bowel. And so she would have a little bit of a skin reaction, and that would be pretty much it in terms of her short-term side effects.
What about long-term?
Long-term, who asked that? Long-term, yeah, that's a good question. So there are always two kinds of side effects, short-term and long-term, to this kind of treatment. And they're all, again, location, location, location. But short-term you can think of as suntanning and sunburning or inflammation inside and out to the area. So you can get suntan and sunburning in these areas, but it's all dose-related. So to further complicate things, some diseases get very high doses, like prostate cancer. We give 8,000 rads for prostate cancer. Breast cancer, 6,000 or 7,000 rads. Head and neck, 7,000 rads. Lymphomas, this got 2,400 rads. So it gets a very low dose in comparison to other cancers, and so the side effects are much, much less. Some lymphomas get 3,000, sometimes up to 4,000, but very rarely ever do they get 7,000 or 8,000. That would be highly unusual. So the doses, because they're so sensitive to radiation, we can melt away lymphomas with 2,400, 3,000, or 4,000 much easier than we can certain prostate cancers or head and neck cancers with much higher doses. They're just very, very sensitive to treatment.
Are the doses cumulative? So suppose you have radiation twice in two different parts of your body close together. Is it cumulative?
Good question. So you can have radiation more than once in certain circumstances. It just depends.
Or different areas?
Clearly different areas you can.
But is that cumulative in your body?
No. No, it's all site-specific. So if you're radiated to your jaw and then you got breast cancer, that has nothing to do with the jaw radiation. You can get full-dose breast radiation and not worry about it at all. But if you got something else in your jaw and needed treatment again to that same area, more problematic, much more problematic. Well, I talked about some lymphomas are in strange places, and so one of the more common areas to see certain lymphomas is in the eye. And the eye is a very complex structure, as you can imagine. It's got a windshield called the cornea. It's got the lens that gets cataracts. It's got the retina, which is the movie screen for vision. It's got the lacrimal gland, which makes tears, right over here. It's got the lacrimal duct, which collects tears, over here. It's got the eyelashes, the eyelid. I mean, it is very complicated and very sensitive. And this is your eyeball right here. This is an eyeball. And this is a tumor. This is a tumor. This is a tumor. This is a tumor. And so these tumors can occur in places that are not particularly friendly. Fortunately, most of the kinds of tumors that happen in the eye are very sensitive to radiation, and we don't have to use very, very high doses. And so we can sterilize this kind of tumor 95% of the time if it's a malt or indolent lymphoma with relatively low doses of radiation and just cause some temporary irritation and be very curative. This is an example of what we call whole orbit radiation. Everything in this area is being treated. This is his head, brain, eyeball, right in this area. So here's the tumor right here. This is another way of looking at it. And this is an example of how fancy we can get if we want to. If we want to. This is a fancy technique called intensity modulation. We don't use this on everybody, but we have this capability should we so desire. This is the eyeball that's normal. The tumor's in this area over here. That's his lens right there. And you can see how eloquently we've carved out the dose of radiation to be in this area and spare his lens, and so reduce the incidence of cataract, because the lens is very sensitive to X-rays and you can get cataracts pretty easily. And so we're attempting to spare his lens because the tumor is back here. And this is not a standard treatment. This is that would be a very sort of expert treatment that would be available in very few places, I would think.
Does it affect the retina?
Great question. So that's a great question, and that brings up the vast difference in the tolerance of radiation to every tissue in the body. So every tissue in our body has a different tolerance to radiation. For instance, the kidneys can handle a different dose than the bowel, can handle a different dose than the liver, can handle a different dose than the salivary glands, can handle a different dose than the lacrimal gland, can handle a different dose than your heart. And so part of our job, why we do 5 years of training after medical school, is we have to memorize all those and know what's safe to give. One of the most sensitive structures in the body to X-rays is the lens. Now, if you give x-rays to the lens, I can give somebody a cataract. If they're destined to get that cataract at age, I don't know, 70, we can give it to them at age 35, 45, 55, depending on. But a cataract is not a deal breaker, right? A cataract is now, in the modern era, a 15-minute procedure that can take care of that. And so we won't necessarily, not that we want to cause a cataract, but we won't try to be super fancy if there's a tumor near the cataract because it's a cataract. The retina in this area, the retina is the movie screen for vision. Light comes in and hits the retina. Now that is not very negotiable because if you overdose the retina, you can cause someone to be blind, obviously. The retina can handle 5,000 rads generally, where the lens can handle about 1,000. So there's a vast difference between what this can handle and what this can handle. And since we're going to around 3,000 for this, the retina should be very safe with this kind of treatment.
Can I ask a question?
Yes?
How is that diagnosed?
This kind of tumor?
Yeah.
The patient will generally feel something or have some kind of visual problem because what's happening, let's see. If you've got a tumor here in your eye, this structure right here, this little snake right here, that's your optic nerve. That's what takes the signals from the retina and sends them to your brain. This optic nerve is being pushed on right here. You see that? It should be a straight line. It's got a nice curve to it. You start pushing on the optic nerve and you can have visual problems. Number one, you can also have muscles in the eye, right? We've got our muscles which move our eyes up, down, right, left. There's different muscles in the eye. And this tumor will be pushing on those muscles. Now that causes a big problem because normally our eyes track perfectly together. But if one eye has muscles that are being pushed on, causing that movement to be different, now you're tracking differently and you'll get double vision. So lots of people come in with blurry or double vision because their muscles are not allowing the tracking to be coordinated anymore.
What about blood levels? White blood cells?
I mean, that's not generally how it comes to people's attention. It's usually a symptom, but these wouldn't necessarily show up in the blood that readily. Not this
Do you
particular
have
tumor.
some physical sensation like pressure?
You could. You certainly could. These can get pretty big. This particular tumor is all of this and back in here. And so that would be, also people might say something to you. You could have your eye, this will gets big enough, it'll push the eye out. And so one eye could be further out than the other. And that, somebody could notice that.
You talk quite a bit about the quantity of radiation. Do you consider the energetics of it?
I'm not 100% sure I understand exactly what you're asking.
Well, the voltage.
Yes.
Are some tissues, I don't know anything about this, are some tissues more sensitive to one energy level than to another?
That's an interesting question. So generally, no. The way we use energy is a little different than you might suspect. The way we use different energies, because our machines, and maybe this is a good time to switch topics for 1 second. I'm gonna use your question as a launching point to switch over to this. We have different machines that are capable of producing X-ray beams of very different energies.
Yeah.
We can produce photons and electrons. The different energies are used to deliver dose differently. Photons go through you to the wall, and electrons, I can treat skin cancers, and then it can only treat something this deep, or this deep, or this deep, or this deep. And so we can tailor the X-ray beam by using different energies. That's really how it's used. This is a ViewRay machine. I'm going to actually play a little video about it if I can find it. Let me do that for a second. Let me try one thing for you. Do you guys want to watch a little video? Sure. Is that okay? I'm going to play you about 5 minutes of our new patient video, and then I'll play you about like 2 minutes of this ViewRay one. The ViewRay machine, which is this machine right here, it's actually very interesting.
Anything to do with the rapid arc?
We have rapid arc too. We've got an impressive array of equipment. We have 4 different types of machines in Westwood. They're all very different, and so we can tailor what's best for the patient and what machine to put them on. Rapid arc's not actually a machine, it's a technology on a machine, right, that we might have used for prostate or something like that. You'll meet my chairman, Dr. Steinberg. Maybe some of you know him, Mike Steinberg. He's the chairman of radiation oncology at UCLA. Very nice guy. He was the president of our National Society Astro a few years ago, and he has taken the UCLA Radiation Oncology Department into national prominence, which is, I'm delighted to say, and so he's done some great things for Los Angeles in this regard. Let's see if we can hear this. I'm going to play just about 5 minutes of this. I'll step up.
Welcome, and thank you for choosing UCLA Health Radiation Oncology for your care. I am Michael Steinberg, Chairman of the Department of Radiation Oncology at UCLA. This video provides instructions and information on what to expect before, during, and after your treatment. You can be assured you will be cared for by expert physicians and our professional and compassionate nurses and staff. If you have any additional questions after watching this video, please do not hesitate to ask your doctor or one of our staff. We are committed to providing you with the highest quality of care. We are here for you.
The UCLA Radiation Oncology Department is dedicated to making sure that your treatment is delivered in the safest and most accurate manner to the right locations and in the correct amounts. Your treatment is a team effort. Your radiation oncologist develops and oversees your treatment plan and monitors your progress. A medical resident or fellow may work with your radiation oncologist in managing your care. A team of nurses and medical assistants will help you during your visits and with any possible side effects you may experience. Your radiation therapist delivers your prescribed radiation dose at each session. The dosimetrist calculates your precise radiation dose in order to minimize radiation exposure to healthy tissues and organs. A medical physicist oversees the work of your dosimetrist and helps ensure that complex treatments are properly tailored for you. Your social worker is here to support you and your family. A navigator will contact you prior to your first appointment to make sure you are prepared for your visit to our department. We also work together with your surgeons, medical oncologists, resident physicians, and your own family doctor to ensure you get the best and safest treatment possible. During your first consultation, the radiation oncologist will perform a physical, review images, and make a recommendation. If you decide to proceed with treatment, you will be scheduled for a simulation appointment. Treatment begins with a planning session called a simulation. The radiation must be aimed precisely at the same target each and every time treatment is given, and this planning simulation helps ensure accuracy. The therapist will position you based on the physician's instructions. You may be fitted with a customized device such as a vacuum bag, which is used to hold your body in place for the treatment, or a plastic mesh mask, which is used for treatment to the head and neck. Your therapist may draw marks on your skin or on the customized device during simulation so that your exact position can be used for every treatment session. In some cases, we may also recommend a permanent tattoo the size of a freckle. The therapist then goes into the control room to closely monitor you. Our staff can see and hear you at all times, and the machine can be stopped at any time. Lights are used to help confirm your precise alignment. These lights are not harmful or painful. They are solely for positioning purposes. After the simulation, we will help you schedule your treatment appointments. Before your next visit, your radiation oncology team spends many hours collaborating on a treatment plan specifically tailored to you. This also includes quality assurance testing of your plan to ensure your treatment is safe and accurate. Radiation therapy is painless. The beams are directed precisely at the treatment site. At UCLA, we have many types of radiation machines, and your doctor will determine which one is best for your care. When you arrive for your daily treatment, you will check in using the barcode scanner, which informs the therapist team that you have arrived. At each visit, our board-certified therapists will position you on the table to make sure you are properly aligned for treatment. Treatments are scheduled for weekdays. While some patients require less than 5 treatment sessions, patients can typically expect 5 to 7 weeks of treatment. The length of treatment time can range from 15 minutes to 20 minutes, up to 1 hour in some cases. The size, location, and diagnosis determine the number of appointments and length of daily treatment. You may bring a friend or family member to your appointments, but they cannot come inside the treatment area. At the time of simulation and on your first day of treatment, our team of therapists will walk you through the experience, answering any questions you may have. Your treatment may include additional imaging within the department. These additional MRIs, X-rays, and CT scans help us confirm the accuracy of your treatment and positioning at every visit. Radiation therapy is usually given as a series of outpatient treatments. The majority of patients will not need to take a leave from work or require extended recuperation periods. You will have a weekly check-in called an on-treatment visit with your radiation team to discuss any concerns, review your progress, and answer any questions. You can also communicate with your care team at any time using UCLA's online patient portal, my.uclahealth.org. As one of the country's leading academic medical centers, UCLA conducts important cancer research. Some studies help us learn more about cancer in the hopes of developing new treatments or cures in the future. Other studies are designed to provide specific benefits to the patient. A team member will reach out if there's a study that could be a good fit. Your treatment plan includes education about side effects. The specific side effects you may have depend on the type of radiation, the dose, and treatment area. Side effects vary from person to person, and your reaction to a treatment may be completely different than that of another person receiving the exact same treatment. Please discuss any concerns with your doctor or nurse. The area of the skin where you are receiving treatment may become red and sensitive, similar to a sunburn. Our nursing team will provide information that will help you care for your skin. Most patients are able to eat normally and follow their usual work and exercise routines during their treatment. Your doctor will discuss what's appropriate for you. By the end of your treatment, you may experience fatigue, so it is important to make sure you are well rested. It is common to feel anxious or nervous. We encourage you to talk about these feelings with your loved ones or any member of your treatment team who can connect you to the many resources available at UCLA. After your treatment is complete, follow-up appointments will be scheduled so that your radiation oncologist can make sure your recovery is proceeding normally. Your doctor may also order additional lab tests or imaging studies. As time goes by, the number of times you will need to return to our department will decrease. However, you should know that your team will always be available should you need to speak with someone.
We hope this video has been helpful in answering some of your questions about your treatment. We understand this may be a challenging, emotional, and sensitive time for you and your family, but you can be assured that all of us here at UCLA Radiation Oncology will do everything we can to keep you safe comfortable, and on your way to a successful recovery. If you have any further questions, please talk to your doctor or one of our staff. We are here for you.
So that video is
So most of those machines are closed tube?
no, only one. Only one. Yep, all the rest are open. So we have one special machine called the ViewRay, which is based on an MRI. It's one of only 3 machines in the world currently. And so it's a very special machine that all other machines are based on CAT scans. The ViewRay is based on an MRI, and it allows us to literally track certain tumors live. And so some tumors in the lung, in the abdomen, they move with respiration, they move with the heartbeat, or they can be in different places in different days if it's in the bowel, because bowel moves around. And so with the ViewRay machine, you can track the tumor live and just treat it when it's in a certain place. So it would be the best way to show you is learn how to work the computer.
What strength is that MRI machine? Is it a 1, 1.5?
That's a good question. I think it's a 0.5. It's very low because we're not taking diagnostic films on the MR. So like a 3 Tesla or a 1.5 Tesla. It's a lower one, which makes it much safer to be around. It won't throw an oxygen tank against the wall, right? Hopefully. I'll show you.
Won't suck the fillings out of your teeth.
We're getting a lot of people from around the world and country that are coming to UCLA because of this machine. And
Westwood or Santa Monica?
this is just in Westwood. And my partner, Dr. Percy Lee,
It is one of only 3 radiation devices like it in the world. UCLA has just added the ViewRay to its ever more sophisticated arsenal against cancer.
Finally, we have a tool that we can visualize the cancer while the radiation beam's on for the first time in the world. So it's very exciting, and we truly believe it's going to impact and improve the outcomes of our patients at UCLA getting radiation therapy.
Traditionally, doctors use a CT scan in a so-called simulation to help plan a precise and comprehensive treatment strategy, relying on patient positioning and tiny tattoo markers on the skin to line up the radiation beam. But the ViewRay adds the most highly detailed MRI imaging, live in real time, to keep the radiation beam directly on target during the treatment itself.
We know that tumors in normal tissue move around all the time. We need to adjust for that, and this machine finally allows us to do that in real time.
You can see this lung tumor outlined in red with margins in green moves when the patient is breathing.
If the target moving out of our designed target area, the tumor moving out, the radiation automatically stops. And until it's moving back, it start the treatment again. So we call it gated treatment.
This gated on-off treatment ensures maximum radiation to kill the tumor while sparing healthy tissue should it move into range. Margaret Vandenbree is one of the first patients to undergo treatment with the ViewRay at UCLA for pelvic cancer.
I'm going to speed this up for a second.
It's very comforting to know that they're getting it right on the spot.
So what it does is it shows you, this other video is very interesting, and I can't find it right now, but the machine actually turns off. So when the tumor leaves the zone that we've decided it should be in, the machine stops the radiation, and when the tumor moves back in, it starts the radiation. And it does it automatically. It's called respiratory gating. And it does it live. Respiratory gating's been around, but not watching things live. And so you're able to, I can't describe after 20-something years of actually watching a tumor live is a remarkable thing. So the accuracy is sort of unparalleled. And there's a lot of excitement and buzz about this kind of machine, where now the other manufacturers are starting to decide that they're probably going to be building MRI machines as well. So, yes, yes, ma'am.
Where else is it located?
One is in Missouri, Washington University, and I think the other one's out of the country, if I'm not mistaken. So,
Who makes it?
ViewRay.
Oh, that's the
It's the name of the company, and you'll start seeing they're going to be selling lots more of these. So they'll start. I mean, they're not cheap. They're about 2 or 3 times more than a regular radiation machine right now, and we're talking millions of dollars for a regular machine. These can be $8 or $9 or $10 million for a ViewRay machine. So they're not insignificant expenses.
Are the insurance companies resisting using these because they have to pay more?
Well, they don't necessarily have to pay more. It's still a radiation treatment. So the billing is essentially the same. There may be 1 or 2 extra little billing components for MR, but generally it's the same kind of billing as the other machines. So yeah, unfortunately, I don't think the billing correlates with the price of the machine. Yeah, or fortunately, I should say, yeah.
Talking about machines, doctor, can gamma ray tests in gamma ray machines cause any lymphomas or leukemias?
These are basically gamma ray machines. That's the ViewRay.
Gamma ray?
Well, gamma ray is an X-ray. A gamma ray means X-ray, and so when an X-ray comes from a X-ray machine,
It's called an X-ray.
we call it an X-ray. When it comes from a source, like plutonium or uranium, we call it a gamma ray, but it's really an X-ray. They're the same thing, their origin is different.
That's why it's called nuclear medicine, right? If you gamma ray nuclear medicine?
Yeah, it means it's coming from the nucleus of the cell.
They put people in those gamma ray machines like for a half hour, okay? And then they infuse them with a dye. Then they are in the gamma machine for a half hour, then they're on the treadmill, they're back in the gamma machine for another half hour. Can that be damaging or to any?
I'm assuming you're talking about like a cardiac exam perhaps at that
Right.
point. Yeah, so different diagnostic tests have different levels of kinds of radiation that they use, right? Right? But that's no different than the PET scan. The PET scan I showed you is radioactive too. CAT scans are radioactive. So there's clearly a lot of X-rays being given to people in this day and age.
Hundreds of pictures.
Yep. And so can that cause cancers in the future?
Or leukemia or she has
It could. It could.
Non-Hodgkin's lymphoma. Okay, you're talking about radiation, but when I talk with her mother, they live in Michigan. She's been on.
That's where I'm from.
Oh, okay. She was at Mayo's. Now she's at the University of Michigan Ann Arbor. She's been on Bexar and Rituxan.
Those are different kinds of drugs, yeah.
Okay.
Right.
But I don't think her mother has ever told me that she was given any. It must be a different kind of lymphoma. She doesn't.
Right. Some lymphomas only get drugs. Some lymphomas get surgery and radiation and drugs, and so it depends on what it is and where it is. So it would be hard to say for a particular person in Michigan, but there's a constellation of treatments that each patient might get. I have another question over here.
Well, and I have lymphoma as well, not non-Hodgkin's. And I had heard, and I haven't done it, I know friends who have, there's a targeted radiation where you take some kind of radioactive liquid and it goes, I don't know how it works, but bottom line is that when you get radiated, it only radiates the cancer, it only destroys the cancer, as opposed to everything in the area.
Right. You might be talking about, yeah.
Isn't that Bexar?
Bexar.
Right. So one of these drugs is possibly what you're talking about is the Rituxan molecule that's then radiated, which then has an affinity for these receptors on the cell, which can then be more selective. That's more of a medical oncology type of treatment, even though it has a little bit of radiation in it. It's not something that we would do in our department.
For a week, you have to be separate from people.
Yes, absolutely.
Yeah.
Right.
I think it
She
was
was
invented at the
isolated.
University of Michigan, actually.
Right, because that is actually something that you're given internally. That's not, so our treatments, the ones we're talking about today, are X-ray beams that pass through you and do not leave you radioactive at all. Those kinds of treatments are drugs that you're given, circulate in the body, and then when you attach some radioactivity to the drug, you become radioactive for a while until you excrete that drug.
How do you attach the radiation to the drug?
Well, we don't. It's done in the lab. That's the drug is it's a drug you have to buy. Yeah.
But it's a drug, but it's radiation.
Correct.
Right.
Yeah.
Get it.
A friend of mine had breast cancer with lumpectomy, and she had was at the area of her surgery. It was a little tiny thing. It looked like an egg beater, she said.
Yeah. Want to see a picture of that?
Yes, I'd love to see it.
Sure.
She wore it for a week, and it targeted her, the area of her tumor. This was in
Now,
Arizona.
we're going to go slightly off topic here, but I think that's awesome. Since I run the breast center, or the breast program as well in Westwood, I'm going to show you exactly what you're talking about. There's some of the members of our breast team. I'm going to...
She was just speaking here. The blonde on the left. Yeah.
Dr. McCloskey.
Yes.
Yeah, she's awesome.
Yes, she is.
So these are the kinds of treatments that are, some of the treatments that are available. This is whole breast therapy, right? So this is a breast, heart, lung, spinal cord. And this is a beam of x-rays coming through and treating this whole breast area, the chest wall, muscles, ribs, and the sliver of lung right here. That's what 90-something% of women in the country get after lumpectomy, is whole breast radiation therapy. We've been doing this for 30, 40 years. Our techniques are slightly better than they were back then, but that's a very, very common type of treatment. What someone else you're describing is called partial breast radiation, where we don't treat the whole breast, we treat part of the breast. And these are different techniques that we offer. This is the one you're talking about. This is actually the egg beater you're talking about, where it's a balloon. This is another type of balloon. This is an actual balloon, where you put one source of radiation right there, and the radiation goes just to this kind of red area, and the rest of the breast is not radiated. That's called partial breast radiation. Some women are candidates for that. This is a more sophisticated version of that. You would call it the egg beater. You can put radiation in each of these sites, and by manipulating how much radiation goes here versus here versus here versus here, you can create very intricate patterns and spare some of the skin or chest wall a little bit differently than you can with this one. This is a very conformal technique. It's actually needles that are placed into the tumor area, resection cavity. And this is a partial breast done with external beam with no implant at all. And our latest, which isn't on here, is the ViewRay doing this kind of treatment with no implant at all, partial breast, and reducing the volumes because now we can watch it live. And so that's what I've started doing at Westwood, is using the ViewRay for partial breast treatments.
Now, does this ViewRay steer the beam or modulate it in any way?
It is capable of intensity modulation, yes.
And who manufactures?
ViewRay,
That's the name of it.
yes, yes, that's right.
Hooray for ViewRay.
Hooray for ViewRay. Any other questions? I see my signal being given over there, perhaps to wrap it up. I'm not sure what that means.
Thank you. I have a question.
Yeah, of course.
If you've had surgery and because you had cancer, like I had it in the pelvic area, and then you do chemo, and then before radiation they do a CAT scan, if it comes back clear, and they're still going to do radiation, but there's no tumors to target, number one, what do they target? And number two, would the ViewRay machine be good for that if there's no tumors?
That is a great question. So I have no idea what you had, but let's just assume what happens very commonly is people have surgery, and then radiation is used like after lumpectomy, for instance. We'll give you an example. There's no tumor here, it's gone. They've had surgery to remove the tumor. We're using radiation to destroy microscopic disease, in this case, that may still be there. And so that's what the radiation is used for in that case as well. If you've had surgery for rectal cancer or cervix cancer or something in the pelvis, uterine cancer, sometimes there's a high enough risk that there'll be microscopic cells that we will then recommend radiation. We'll treat the pelvic lymph node regions where the uterus was, and then the pelvic lymph node region. So there's external iliac, internal iliac, and different kinds of lymph node areas, and we target those areas in the pelvis in that kind of situation. Not necessarily.
Okay.
Not necessarily in that case.
Okay. Thank you.
Probably would not use ViewRay for that, but
Oh, all right.
Yeah.
Isn't that just sort of random? You're sort of
What's that
looking
mean?
in an area. You know, there might be some microscopic cancer cells there, so let's go in that area, and if they're there, we'll get them.
You're gonna
But
kill
it's not,
everything else
it's
in the area
it's not
too.
precise.
Well, here's how I would answer it. We know what areas we're looking at, right? It's not random in that, for instance, in breast cancer. Let's take breast cancer. So if we were to fully answer that question, so if I were to show you pictures of breast lymph nodes, for instance, let's say here, and when somebody has a lumpectomy, right, they have a surgery on the breast, right, they might take out the lump, and then you have these little lymph channels, and when they sample your lymph nodes under the arm, they're sampling here. Now we've broken down, not we, but the medical establishment has broken down the lymph node areas into 5 different areas, right? Level 1, level 2, level 3, and level 4 up in the neck, and then the internal mammary lymph nodes that lie along the breastbone. And so it's not really random, right? When you get the radiation treatment, we're treating the breast or resection cavity, and then levels 1, 2, 3, 4, and possibly the internal mammary lymph nodes. So I would suggest it's not random, but it's an area at risk, depending on the pathology and things like that. Yeah.
So does that mean if you have a breast cancer, they always also radiate up here? Is that what you just said?
We only radiate the breast area in certain people, and if other women have positive lymph nodes, then we'll radiate up into here. And yes, we radiate right up into the low neck. That's correct.
Is this related to the sentinel node biopsies?
If the sentinel node biopsy is positive, the sentinel node biopsy comes from right here. So we're assessing risk up the chain,
I see.
right? And it's more, I'm making it sound simple, but it's more complicated than that, like any question, right? We're looking at not just number of lymph nodes, size of metastasis, whether there's something called extracapsular extension. There's different pathologic factors that make the risk higher or lower for certain women and enable us to make better recommendations.
When you get the nodes up in the neck, is it easy to avoid the thyroid?
Sometimes. It depends on someone's anatomy. Everyone's anatomy is completely different, right? So we literally go into the CAT scan and draw by hand. I draw by hand on every woman in Westwood that comes in for breast cancer treatment. We draw the chest wall, breast area, levels 1, levels 2, levels 3, levels 4, and internal mammary if we're going to treat those. We draw those on every single woman, and they're completely different on every single woman, right? But it's all done individually.
Every single woman in the married ones too, huh?
All right, we have gone from lymphoma to breast cancer. Any other cancers we want to talk about? Ovarian. Do you have a specific question about ovarian cancer?
About ovarian cancer and radiation therapy.
What about it? Oh, that's an interesting question. Wow, let's see. So I am now old enough, I'm 51. I graduated residency in 1995. And back when I was a resident, radiation was used for ovarian cancer quite extensively. And there were some studies run back in the late 80s, early 1990s, looking at, do you remember that really old technique I showed you in the beginning? Do you remember the, you asked, I'll just, since you asked. That's called the moving strip technique. Now when we look at it, it looks pretty archaic, doesn't it? Because what they did, this is before CAT scans, this was back in the 70s and 80s, they took a woman, because they wanted to treat this whole area, but we really didn't have the technological capabilities. So they treated this area, then they treated this area, and then they treated this area. Now you can imagine this is not the most precise or best way to treat somebody. Like if I suggested we do this today, I might be thrown out of UCLA, right? This is not a current technique that is offered in the world or in the country. This technique was compared to chemotherapy in a study in the late 1980s, and the conclusion of that study in just ovarian cancer patients was that they were equally as effective, right? The chemo and radiation for certain patients was equally as effective, but there were more side effects with the radiation because this was the technique they were using. It was bad. Based on that one study back then, the establishment decided that we would use chemotherapy for most ovarian patients and not radiation. Not that radiation is not effective. It's very effective for ovarian cancer in certain circumstances. But it just got lost over the decades. And so now women are getting lots of chemotherapy for ovarian cancer. I'm seeing quite a few ovarian patients these days that have unfortunately maybe run out of chemotherapy options, or are looking or have certain isolated areas that need the ViewRay or need a specialized technique that we can offer. And ovarian cancer melts away pretty nicely with radiation, so we're seeing a lot of patients that are not responding anymore to their chemotherapy these days. So yes, if that is helpful in any way.
I like that phrase, melt away.
You like that?
Yeah, that sounds less awful than, other kinds.
I could use some other ones that we do. We obliterate.
Those who came in your name, Doctor?
Phil Beron.
B-A-R-O-N?
B-E-R-O-N. Right.
Do they still do a whole pelvic radiation for prostate cancer?
In certain circumstances, yes.
Rip
Yes.
all the lymph nodes?
It's just for certain circumstances. Mostly not. Mostly just the prostate area. But sometimes we treat, for higher grade lesions or more advanced lesions, we certainly do, yes.
Any words to say about brain cancer?
Do we really want to get into brain cancer today? Maybe we should end on an ovarian note. Anyway, thank you very much for having me. I hope that was helpful in some way.